Good morning. Welcome and thank you for joining us for our Northern Light Health Good Health is Good Business Zoom conference. Today's session looks at digital solutions leading to healthcare cost savings. We'll discuss benefits design that considers new digital solutions and what trends are showing. Telehealth will be featured as one of the digital tools to enhance employees' access to healthcare. We won't have a COVID-19 update today, but I'd be glad to answer any questions that you may have during the Q&A section of today's session. We do have much to discuss, so let's get started. Our panelists today are Dr. Mike Ross, Chief Medical Information Officer at Optum Insight and practicing pediatrician at Northern Light Health. Mike Sisk, Vice President of Benefits at Cross Benefit Solutions. During the Q&A session, as you can imagine, as tempting as it is, I won't say, this next question is for Mike. Okay, I'm Dr. Ed Gilkey, Senior Physician Executive at Northern Light Health. I'll be your moderator for the next hour. Before we get started, I will read our legal disclosure. The information presented in this session is provided for educational purposes only and is not meant to substitute professional or medical judgment. Northern Light Health does not know the particulars of your situation, so the information presented today is intended to be general in nature and may not apply to every individual situation. Northern Light Health and the presenters make no guarantees or warranties regarding any information provided. A reminder, this hour is for you. If at any time you have a question for our panelists, please use the Q&A function. I'll keep track of your questions and have our speakers respond. Also, I hope each of you will take a few minutes immediately following this hour to answer our quick 5-question survey. Your input directly affects our topics and helps guide our future conferences. Mike Sisk will start us off with a look at benefits design strategies. Mike?
Hey, good morning, Dr. Gilkey. I first want to say it's just an honor to have the opportunity to speak to this group. And personally, and on behalf of Cross Insurance, I just wanted to tell you how much we appreciate being invited to share insights and observations today. So I'd like to start the discussion today, maybe talking about where we are now as we think about the status of employers and plan sponsors. And I think this slide here is a fair representation as to where most employers and plan sponsors are with their strategic initiatives specific to benefits and what I'll call cost avoidance. Reducing trend with core plan features and services. Those have been in place for a while and they continue to evolve, but they're really foundational to what most employers offer. Driving healthy behaviors by removing cost barriers where possible and outreaching, different forms of outreach to help and support members in need. Then, of course, motivating behavior change in hopes of affecting health, productivity, and ultimately cost. All of these fronts, we believe, are important to the overall strategic goal of predictable and sustainable cost. I think we are all looking for that ultimately, but we're also looking for valued benefits and protection for employees, attraction and retention of the workforce. I think we felt this acutely over the last, it's hard to keep track, maybe at least the last 2 years with the challenges in the workforce and simply finding people to work. And we know this is a challenge for nearly every business. And then value-added offerings that are designed to promote health and well-being and productivity, but also differentiate when competing for talent, because as I just mentioned, finding talent is a challenge in the marketplace these days. So all of these things need to be deployed in a successful strategy. And achieving these goals requires both relentless pursuit and, I believe, eternal vigilance to keep time with evolution, a consistent cost challenge. I mean, that's just not going to go away, I don't believe. And changes, both anticipated and those that come as a unwelcome surprise, I should say. So listen, as we think about an unwelcome surprise, I believe the pandemic was really a vivid example of that. But the other thing it was an action forcing event. Much changed. I think we all know that. It has remained changed for all of us. And when I think about that, I guess, listen, the list is long, but I think about things like, congratulations, we all participated in a health emergency. Maybe most, if not all of us, for the first time. We needed to process, communicate, and deploy benefit changes in real time. And that's not really what we had been used to. We normally follow a 2 to 3 month implementation plan and do it once at open enrollment. So that was dramatically different. We came to be familiar with terms like furlough and contact tracing as they entered the lexicon of our business. And many of us learned to work in different ways and adopt new technology quickly. Listen, I don't think there's a need to belabor this. I think we all get it. We lived it, and we have more than our shares of stories and personal perspective. But what I have noticed that I believe is a remarkable change that COVID did push through was an overnight adoption of virtual technology. And listen, our meeting today is proof, but also in care delivery. Some insights that I've got here that I want to point out that came from a recent study conducted by McKinsey and Company measuring virtual care utilization in 2020 to 2022 and how that virtual care has expanded. I think these stats are really interesting when you see from the pre-pandemic period through the end of the measurement period, there was a 17% overall usage of virtual care when it was 1% or less pre-pandemic. And then when you start to break that out into categories, you see 5% for procedural specialties like urology and gastroenterology, but 14% for other medical specialties. And that's something I think we can all probably associate with challenges that we've noticed in the population over the last couple of years was a 54% adoption for behavioral health specialties, peaking at a high of 72%. For me, really what is most noticeable there is the sustainability of virtual care for behavioral health visits. As we've all become more comfortable with transacting business and personal connection virtually, the delivery of care has expanded in a measurable way and offers, in my opinion, much optimism for an evolution or at least more choice for the future of care delivery. So when we're talking to our clients at Cross Insurance, we ask, when it comes to the topic of virtual care and the adoption of technology, we ask them, does this matter to you? What is the opportunity available? How does this fit as a strategic initiative of your organization? And then how does this support other initiatives that are of strategic importance, such as equity, convenience, and access? And as we look at the things that I think we've come to know, and I have certainly come to appreciate that virtual care offers, and I'll step back for a minute and just say, I don't think virtual care is an answer to every sort of care, certainly not every type of specialty, certainly not a fit for every type of circumstance, but I do think it has a place. And as we think about that place and what we want to do with that, some things that are apparent are really the expansion of care options. Listen, we can supplement some geographical limitations that currently exist, and we can provide some equity and resources that may not be available based on people's geographic location, whether it's rural or in an area where care delivery services are simply not available. I think I want to step back for a minute and acknowledge in the state of Maine, as rural as the state of Maine is, there's some obstacles here that are real obstacles to virtual care, like bandwidth issues. So I do want to recognize that, and I don't want to gloss over that. But I do think for a lot of folks that there's an opportunity here to access care virtually that may expand the access that they otherwise would have had available to them. And then I think about things that are real life, convenience. We all have challenging schedules. We know our employees do. There's logistical issues with getting care. I mean, we all know about it. We've got to block off time on our calendars. We've got to travel there. We've got to wait. Listen, I don't need to belabor that, but we just know the logistics of getting care sometimes is really a challenge. And we know it impacts our families and our coworkers at times as well. We're all developing personal preferences on how we like to have care delivered. I think for a long time, there wasn't much of a personal preference option. It was a single way of going to the doctor, going to the dentist, or somewhere else. But now we're finding there are options. And I think we like that. And I think somewhere along the way, maybe we're building our preferences as well. And then last is simplicity and connectivity. I mean, what could be easier than having a meeting like this in my office or at home or frankly anywhere else? But I think it also addresses some challenges that we face as well. And we certainly hear about, read about, and maybe experience, which are issues like provider scarcity. Hey, it's just tough to find a provider these days. PCPs are even tougher. Wait times, hey, that can really be a challenge, especially if you want to get care now or a loved one you feel needs care now, and it's creating a level of, well, pain or at least anxiety. And the last is health risks. And COVID has made us all acutely aware of health risks and exposing ourselves to health risks. And then the downstream effect of other people in our lives, coworkers and loved ones, and the exposure we create for them. And let's face it, virtual care, it's hard to catch COVID from having a video conference with someone. And that presents a real opportunity as well. So I think there are some strategic fits here that make a lot of sense. So then the next thought is, okay, so what do employers do about this? They can accept it. They can have optimism about it. They can even have excitement about it. But what does an active adoption of virtual care look like for an employer or plan sponsor? And with our clients, I guess I'll just surmise this and simplify it. So we've really seen two approaches. One is a plan design. It's a plan design modification that's intended to create a financial incentive or to remove barriers to care. The goal here is to eliminate or reduce the cost to encourage usage of virtual care, to help finance the cost of care. And that's really just a challenge for any type of care, but there's an incentive here as well, maybe more so than in some other ways. And that is because in many cases, the employer has an opportunity to enjoy the lower out-of-pocket, or I should say employer cost associated with virtual care reimbursement. Because in some cases, not all cases, but in some cases, the virtual care reimbursement is less than it would be in a traditional care environment. Another approach that we're seeing, and I'd say it's not as widespread, and maybe this is more progressive, but I think we're going to see more of it, is to highlight a virtual care model as part of the plan design, or really as part of the network to traditional models. Features here can include a virtual primary care physician, can also include a virtual primary care physician with a more expanded team, like a nurse practitioner and a care management advocate and a behavioral health specialist. They can provide home monitoring tools. Scales and blood pressure cuffs are good examples of that. And then they also rely on referrals to traditional care models when the patient need requires in-person care, or promotion of a model that offers expanded services well beyond what a primary physician could offer. And I think what's also great about this model is it addresses the variety of needs and preferences of provider engagement within the community of users. And as I mentioned before, we're all developing our preferences in care delivery, but we all share a lot of preferences in how we like to engage with just about anybody. And I don't think those preferences are uniform. And this is simply another flavor, a variety, an option within a network that may appeal to some folks for a variety of reasons, but having it available and promoting it and creating that awareness is certainly going to connect with some portions of the population. When I think about this, really what's in it for the employer, what's the value? And for me, the value can arrive in a few forms that are important and I think strategically supportive of the goals of fiscal management and offering value-added benefits. And the things I think about and we talk to our clients about, and I think they've come to embrace, are the reduced cost of care. When there is a reduced cost of care for virtual care, it helps associates and their families finance healthcare. And the financing of healthcare is getting more challenging every day, particularly with the advent and widespread adoption of high deductible health plans. To the extent that virtual care is delivered more efficiently, and by efficiently, I really mean less expensively, it helps manage the bottom line and apply downward economic pressure to the delivery model. And we're always looking for, I started this conversation saying we're looking for trend management, trend reducing drivers. And this is one. I don't think it's the answer in itself, but as I said, eternal vigilance. And this is one of those opportunities to apply some vigilance to the pressures of trend. It offers an expansion of providers, beyond those at a physical locations, and that creates a level of convenience for people. It may actually create an option where one doesn't currently exist, and I think that's got tremendous value. And allows for accessing care in some cases based on what is convenient for your schedule in a setting that is familiar and comfortable without creating logistical challenges and the stress that accompanies them. And I think a lot about stress because most of our clients, when we look at conditions within their populations that are either high cost or driving the highest utilization, it is stress and anxiety is right up there, usually in the top three. And to the extent that virtual care or virtual meetings like today, or the opportunity to work virtually is a reduction in people's stress and anxiety, having virtual care as an option, I think, offers some value in that regard as well. So I would say that's the end of my prepared comments for today, and I'll hand it back over to Dr. Gilkey.
Well, thanks, Mike. We appreciate all that information. Our next speaker is Dr. Mike Ross, who will talk about the Northern Light Health Digital Imperative. This in-depth look should stimulate some thoughts for you to consider. Mike?
Good morning. Hello, everybody. It's a pleasure to be here. It was very exciting for me to scan the audience and see a number of folks here who I haven't seen in quite some time. You know who you are, so great to see you all, and great to see some of you who I have worked with in the past. As many of you know, I'm a general pediatrician, meaning I'm in the trenches. I am seeing patients. I'm using these technologies, as well as a leader in health informatics, what's called a medical informaticist. So I do a lot of work in reviewing and considering and launching these digital projects. And I'll get into a little bit of the history associated with the general strategy associated with this, as well as talk a bit about telehealth in particular, and then kind of broaden it out to more general stuff about general digital engagement. So if we can go to the next slide, please. So when we look at, what makes a program successful, what makes a digital engagement effort successful, like the one at Northern Light, we talk about several main different specific elements. The first one is to have an overall strategy, and one that is supported from the board level down. We started off with a board task force that took a look at this, which has transitioned into a formal element of board governance, and that has trickled down to our second area of second element, rather, leadership alignment, just ensuring that there's focus across the organization, that it's not, that digital engagement thing, that's a nice supplement to our operations. It is a strategy for access. It is a strategy for quality. It is a strategy for care delivery. Nothing works unless it's patient focused, and the health system has not always been one that has been designed with patients in mind. Anyone who spends a night in the hospital and listens to the busyness associated with the hospital environment, which is not always conducive to healing, can speak to that. We've all experienced challenges in finding that those primary care providers, as Mike mentioned earlier. It can be very difficult, and it's not a system that's inherently friendly. And so having the digital wing of that really focused on patient service is a real element of success. And then finally, if it's not clinically valid, it's not worth doing. And Mike has mentioned a wealth of areas where we're starting to see digital engagement, telehealth involve more. I'll speak a bit to those areas and what has worked particularly well in terms of what clinical aspects of care delivery work, what particular subspecialties, what particular avenues, and more general, what general approaches work well. We'll go to the next slide, please. So in order to get to where we had that little pandemic, which made a profound shift in our overall approach. And that has led us to not just partner with our major EMR vendor, but also to partner with lots of other vendors who we've incorporated into our system. But what is super important is to make sure, getting back to that patient-friendly element and clinical efficacy element, is that we have things that work into our system, not something that is, wow, this is a really good telehealth product. We should connect this, or wow, this is a really good program or pattern. We should bring that into our system. It's not so much about best of breed. It's about both what is clinically effective and patient friendly and what connects to the larger system overall. Because if you're doing a hodgepodge of content that's not accessible, you're breaking that first law of patient access. If we'll go to the next slide, please. So when we talk about the different aspects of how we look at digital engagement, we look at first that patient portal integration. If you don't have a patient portal with your provider, I highly encourage you to get one. The portal really was one of the breakout stars of the pandemic and has led initially with that kind of killer app use case of getting results online, has really shifted to become kind of the real conduit for gathering health information. And what we're finding more and more is that is a great vehicle for working with patients in order to provide care. So in our portal, we have opportunities for telehealth. We have opportunities for online scheduling. We have opportunities for some chronic disease management like diabetes care. We look at social determinants of health, looking at different community resources that can provide services. We look at levels of patient engagement that allow us to, when folks have different procedures or specific levels of care, like a pregnancy, that we can have a circular supportive messaging around those. And then also looking at, can we make it easier so you're not handed the always lengthy clipboard at the beginning of every office visit, where you're putting more information in on paper as opposed to having the information, reviewing the information, and signing off. From a provider standpoint, Dr. Gilkey's putting some glossary terms into the chat. I appreciate that, Dr. Gilkey. We do a lot of our work based on the use of a central program called an EMR or an EHR, electronic medical record or electronic health record. And again, if we're flipping between different applications, we're not going to be able to present that entire patient picture. So we look to incorporate these elements together from both a patient perspective as well as from a provider perspective. So if we can go to the next slide and the next one after that. So let's talk telehealth for a moment. Telehealth has grown in leaps and bounds and really is kind of the star of the digital engagement show. It's kind of the first act and has brought us from the pandemic, where it was utilized in emergency fashion, into regular operations. And so there is the virtual visits that was mentioned earlier, connecting directly with a provider, being able to do either a medical visit or a surgical follow-up visit or a wellness visit or a nursing visit. But there's also other areas where we're starting to see telehealth. One of them is the development of a virtual walk-in care that speaks a bit more to offloading some of those patient panels that are so frequent, those visits that can take up a slot and can kind of deprioritize what are some really important medical issues. There's scheduled visits, as I've mentioned. And then there's into some of the more innovative and some of the more extending areas associated with telehealth. The first one is to extend the reach of ICUs. So, in Maine, we've got a very large geographic area. We've got lots of smaller hospitals, all that surround a generally a larger hub. Being able to connect the hubs and the spokes, and also being able to support the hub itself with ICU services is extremely important. And that's something that we've been able to increase our coverage with associated with tele-ICU. The last area is called e-consults. And so imagine as a patient, you're going to go see your doctor and you want to ask about a rash, or you want to ask about a mole that looks suspicious. Your doctor might say, hey, that is concerning. Let's send you to a dermatologist. Or your doctor might say, hey, that looks concerning. Why don't we take a picture of that and I can email it to a dermatologist and we can get a result that can then counsel you on the next steps of care. That latter is an example of an e-consult. And we're seeing that utilized more and more, improving access and reducing costs and improving convenience. We go to the next slide. So we spent about half our time talking about our overall scheduling. I'm so sorry. Overall general approach, as well as our virtual walking care offerings. I'm going to talk for the next 5 minutes or so specifically on elements of digital care. So we talked a bit about utilizing online appointment scheduling, being able to do new visits, adult and pediatric wellness, our general walking care. And if we go to the next slide, we see the results of that. Who knew that people wanted to be able to schedule their doctor's appointments at times that were convenient to them, after hours when they were home and putting all their stuff together, that they didn't want to answer a phone call that was reminding them about a doctor's office in the middle of their busy workday. So we've had a pretty dramatic improvement in being able to improve access to our patients, and also being able to turn around and reduce some of the busyness within the office. If we go to the next slide. One of the very special things about mammography is that due to federal law, you do not need a specific provider order to get a mammogram. And so anyone can present to a mammography site or call a mammography site and have it obtained and have it reviewed. We've taken that and turned that into more of a digital engagement, being able to support patients in their ability to get routine and extremely important supportive health by scheduling their own mammograms. And we've seen that really increase our number of screenings. We've had 1,600 screenings booked directly by patients, and about 7 to 10% were overdue for care. So go to the next slide, please. I mentioned earlier those big medical events that happen that require messaging beforehand, during, and after. Something like a cardiac cath, or a joint replacement, or a cesarean delivery, or a pregnancy follow-up. All of those things benefit from anticipatory guidance and post-event follow-up. And that's what this kind of digital engagement allows us to do. If we go to the next slide. And I'm not going to spend too much time on this one, but this is more focused specifically on our providers, as well as our patients that are in the office, allowing folks to be able to connect and discuss things without the provider having to furiously type all the time, but having an AI scribe that does it for them and supports that so important in-person eye-to-eye contact. If we go to the next slide. So what have we learned? Where do we see things going? Hospital and system board investments continue to grow. We expect what we're seeing here to only continue to increase both locally and nationally. We've learned that patients are hungry for digital engagement, and that we see that especially with our patient advisory boards, as well as our boards that are pushing this. It's really important, and it's a huge lesson, is to let your patients decide what they do and what they don't want. It is very easy to assume that folks who don't have a strong apparent comfort in technology don't want to do this, and that's just not the case. And then last but not least, focusing on your employees, focusing on your patients, focusing on your staff. all of that. It's not one or the other. We're all patients here, and all require that degree of focus and investment. So, with that, I'll draw things to a close. Ed, you'll take it from here.
Okay, well, thanks, Mike, and stay on for video questions. And Mike Sisk, if you would join us, so the three of us for questions and answers. Okay, great, thanks. So, Mike Ross, this first question is for you. So, like all physicians, I know you want all the possible information you can get on your patient when they visit you, including touching. Give us an insider's view from a provider's perspective of what it is like to take care of a patient virtually.
Yes, absolutely. So, one of the things that's really notable about the practice of medicine, especially the practice of primary care, is that in general, the physical exam is to confirm and supplement. It's not to diagnose. We gain about 90 to 95% of the information needed in that discussion, talking about the history of present illness, family history, social history. There are certain situations, I mean, we can't virtually touch a wound, and we can't virtually do a cardiac exam, although some with some technology can. But what we can do is we can obtain a tremendous amount of information and direct that next step, whether somebody needs more urgent care, whether there can be wait for an in-person follow-up. And we can also perform a decent number of exams using the camera. There's basically a full neuro exam that can be done. And as I mentioned, there's some technology that allows us to do things like heart and lung exams.
Great, thanks, Mike. I'm going to jump on that by sharing an anecdotal story. I had the privilege of working for a number of years up in Alaska, and we were supporting the Alaska Native population throughout the whole state with one dermatologist. And having a dermatologist fly to remote areas on a rotating basis is not the most efficient use. And as telehealth, including telemedicine with the capabilities of high resolution cameras in remote environments, came into being, he was able to develop the ability to do consultations, and they called it store and forward. So it would be collected in the primary office in the remote area and then sent into his office. And he was able to take care of 80% of the patient problems that presented using that technology rather than the traditional hop on a plane and fly, as far as 800 miles away to go see patients, and maybe not be available to those patients for another 12 months by the time he rotates around the map. So really, necessity was the mother of invention there, and we could see that now in what's called the lower 48 taking traction, particularly with the shortages that we're seeing for things like dermatology appointments, for instance. So that was great. Mike Sisk, this next question is for you. What have we learned during the pandemic that supports, including telehealth, like the virtual visits you were talking about, in the plan design? So I'm trying to go at like that sort of cutting edge plan design question with that.
Yeah. So I guess I think about two things. The first is that it works. And when I say it works, I really just mean the technology works. I think over the last few years in particular, we've all become fairly comfortable with using technology to connect, whether it's at work or whether it's at home, with our children or watching our children or children to grandparents, whatever it may be. I think we've just become more comfortable with the technology. Now, it doesn't mean that everyone gets it all the time, but I just don't think it's that scary anymore. Some of it was forced adoption and some of it's just evolution, but I think we're all getting more comfortable with the tech. And the tech isn't an outlier to people. I think it's much more of a mainstream. And if you don't know how to use the tech, I don't think you have to go too far to find someone who does. And again, I'm just talking about just the general idea of virtual connection. Falling right behind that, of course, is virtual care and the opportunities that presents. And for me, when I think about that, it's the very basic premise of I can be here being wherever I am. I can be at work, I can be at home, I can be wherever I am, but I can be there too. And I can be in that doctor's office. And where I think about it most prominently is really with behavioral healthcare. And that's such an effective way. Therapy visits are such an effective way to connect, and virtual technology provides that opportunity. And it does so in that type of visit, but really any type of visit, including the ones that Dr. Ross described, without compromise. And I think often we have to face compromise. And the compromise is, how do I be here and there? Well, I can't. So I got to make a decision. And what decision am I going to make? And what am I going to compromise? And I think all too often we think that people probably compromise their health versus what their other obligations are. And I think here there's an opportunity to diminish the need to compromise, because you can be both here and there.
Yeah, I'm going to follow that up, Mike, with a little bit more detailed questioning of you. If you think about Medicare tending to be the front runner and the commercial insurance products, including self-funded plans, following after and paying attention to what Medicare is doing, there's a little bit of a lag in that. And Medicare jumped on the opportunity for virtual care during the pandemic, and then now they're kind of reining it in, putting some more parameters onto it. It's not as easy to access with the expectation of being reimbursed. So with that thought, we've all been exposed, like you said, to this perhaps new way of doing it. Are you seeing barriers amongst employers in terms of the thinking in accepting like virtual care as something that they want to cover in choosing their plan design?
Not employers. I think they
Interesting.
all, yeah, I think for the most part they all have it. Okay, because
Wow.
everyone has had some sort of telehealth component to their plans. Call this number and get televisits. And candidly, the usage on that was somewhere less than 1%. Whether it's pre-pandemic or even post-pandemic, sort of those built-in virtual care networks don't get a lot of utilization. And then when care delivery, in many cases, there was no option other than virtual, we saw a lot more adoption. And I talked about what some of those statistics look like. And I think for employers, they saw what the opportunity was. Of course, they also started to see their workforce in different places and having to accommodate that, the use of virtual. So it all made sense to them. But what we are noticing, and I want to come back to your comment about Medicare and how Medicare is reacting, is we have seen some carriers start to communicate a pullback. And the term we use was liberalization of payment policies for certain types of care that were received in certain environments. So said another way, we'll pay for something that's not received in a traditional environment on a virtual basis because that's sort of what we need to do here in the face of the health emergency. But we've seen that come back. And I think there's some good clinical rationale for that. Certainly not my expertise, but I guess it just makes sense from where I sit, which is some of the home monitoring stuff. Maybe it can only go so far, especially based on condition type or acuity of condition or age or comorbidities, whatever it may be. I can understand that those who are taking the risk may want to have more oversight in the clinical community than a virtual care can offer. So I am seeing some of that pull back a little bit. And I'm not quite sure where that's going to go, but it makes sense to me that there was a liberalization through the health emergency. We've come to adopt a new way of doing business, an expansion, maybe even an explosion of virtual care. And now we have to figure out what to do with that and how to manage that in a new environment.
Yeah, I certainly see adoption of this as being a fairly classic model for human adoption, and behavior change, where the technology was well ahead of the willingness to pay for it. And now the need required, extensive use of it. And now the pendulum is swinging back a little bit to, kind of restrict it so that fraud and abuse is not becoming a big issue that is a topic of discussion. And eventually we'll probably find that narrow zone of appropriate use clinically as well as financially. So it's kind of exciting to see that evolve. So thanks for that, Mike. Mike Ross, I'm going to actually ask you a similar question I asked Mike Sisk and put a little bit of a variation on it. So, what have you learned? What have you seen us collectively learn, not you specifically, but what have we learned during the pandemic that supports including telehealth and these virtual visits? And I'm not limiting you to the plan design; it's more of the clinical approach to it.
Sure. I think we've learned that telehealth, when it was applied to everything, is a challenge. Telehealth, when it is applied to very specific and clinical indications, can be extremely useful. It's been mentioned behavioral health being a major area of investment. Currently, I've heard 50 to 70%, but 70 to 90% of our telehealth delivered at Northern Light is for behavioral health reasons. There are other very specific use cases that are very helpful. So things like surgical follow-ups, where you're just looking at a post-operative wound and you don't need to palpate the wound, or you can have the patient palpate the wound. Having somebody travel 4 hours for somebody to go, yeah, it looks okay. That really is can be accomplished much easier with telehealth. Medication follow-up, especially with things with controlled medication. I saw a question in the chat and wanted to double address that. So that is an area where we're seeing more and more telehealth utilization. We also see some more of those e-consults I mentioned between provider to provider, primary care to expert, with supporting some of those processes as well with treatment for substance abuse. There are definitely some areas where telehealth does not work. And I can tell you as a general pediatrician, I'm not going to be diagnosing ear infections over telehealth because I can't see the eardrum. We don't want to be going and increasing the spurious use of antibiotics. There are certainly some situations that always will require that personal, face-to-face connection, being able to discuss significant issues. Oncology care is not an area where we've seen a significant amount of telehealth, but hematology, blood disorders, endocrinology, which is the study of how our hormones work, and rheumatology, which is joints and arthritis, all of those are very well tended towards telehealth, based on the fact that a lot of those involve the review of blood work. And so you're coming together with your provider, you're looking at where certain levels are at. So perhaps not always for the initial visit, but for follow-up, a lot of those specialties are really embracing telehealth.
So thanks for that. I'm going to grab on something you just said about the otitis media or ear infection. One of the things we saw up in Alaska was we had remote clinics in very remote villages. I mean, everything's by airplane or boat. There's no roads to it at all, and frequently there wasn't a provider immediately available. There might be one in the hub, which could be as far away as 150 miles away in these remote environments. But the clinics in the villages would have the ability for the otoscope, the instrument that looks in the ear, to actually electronically be available at the hub center. So the doctor actually could be looking in the ear, and they were training the medical assistants on how to position it properly so they could look at it. So there's a huge amount of opportunity here in ways that we're not currently even thinking are a good idea just yet. So that's great.
Absolutely. And there are devices that do all in one that can look in your ear, listen to your heart, listen to your lungs, look in your mouth.
Exactly.
Yep. So there are limitless possibilities for the future.
Yeah, so we didn't touch much today on the remote patient monitoring. That could certainly be a whole session at some point, or for clinicians, that's a day or two seminar even. There's a lot to it. Mike Ross, I'm going to ask you another question from our audience. What percentage of patients are utilizing the patient portal in our communities? Now, I'm going to qualify that. I realize that we only have data on those patients that are attributed to Northern Light Health physicians. So that's probably the population we're talking about.
Yes, I think that's a very fair statement. And so my frame of reference comes from uh, those who have a Northern Light Health primary care PCP. So we're seeing about 63 to 65% of patients have a portal and are using it at least once. We try not to involve folks who have just signed up, but we're seeing more than 50% of folks are actually actively engaging on the portal, and that may be more passive, maybe more reviewing results and looking at things after a visit, to active in terms of back and forth communication.
Great. Well, thanks for that. I'll stay on that topic a little bit with you, Mike Ross, for one more. Are patients that could be candidates for telehealth opportunities being informed of options and how? And that's an interesting, and I'm sure you build that into the training of all the providers.
We do. And so it's certainly something we encourage our providers to do. It's something we encourage our offices to do. And we have signage up and things like that. It is an area that we would like to see more development on. Habits are hard to break. And saying, I'll see you back in 3 months, please make an appointment up at the front desk. I mean, that just rolls off the tongue very easily. And so being able to both empower those providers to say, you know what, there are other options for follow-up, and telehealth being one of them, as well as being able to empower that front office to say, we may be able to do a telehealth appointment. Would you like to set that up? And I'll confirm that with your provider. Both of those are active areas that we're working with med staff and are challenges across the nation.
Okay. Well, thanks, Mike. Mike Sisk, this is an interesting concept here. I don't know to what degree you and our audience have heard of the concept of hospital at home. So there's a push to be able to take care acutely, people who have a variety of conditions that normally would be taken care of by a staff in the hospital, but actually are being taken care of at home at a much less cost. And the data is showing that it's equally effective in doing it, probably along the lines of some of what Dr. Ross was talking about, where a lot of the decision making is based on history or the story as it evolves. So have you had discussions with employers about covering hospital at home? Is that up to the discussion phase yet?
No, we haven't had those sort of discussions. When I think about the care here in Maine, and particularly in the large systems that deliver that care, the reputations that they have, the confidence the community has in those organizations and the providers within, that is really the focus. I mean, I think there's a source of pride there, and there's absolutely a source of comfort for patients and their family members to receive care there. And then when I think about that concept sort of in the scope of what's available on a virtual basis, that really seems like a significant evolution to me. That seems like a large leap. And not to say that I don't think it could be effective, effective clinically, effective financially. I think that all sounds great. But I have to say, I wonder whether that would feel scary, scary to people, scared to their loved ones about that receiving that type of care when there was another option available. I think about geographical limitations, and I think about that as an indicator of why there may be some adoption there, why that may make sense, challenges associated with transport. And then I think in some cases, probably less so, because I think when you've got a really acute case, the last thing on your mind is financials. And most of us know if you've got an acute situation, you sort of blow through your financials pretty quick. I mean, things get really expensive for you, and then they don't get expensive at all because you've met your deductibles and your out of pockets, and somebody else is usually paying for care at that point. And I'm not sure that there's necessarily a financial motivation at that point, at least for the patient or their family members to say, I want to try to save some money in the course of managing my acute condition. So not so much with me. I appreciate the idea. I appreciate the concept. And I just haven't had those sort of conversations or seen a demonstrated interest from our clients in that model.
Mm-hmm. So would you say that the next step in exploring that would be a conversation with folks like yourself that really help design the plans, and you really need to understand what the data is showing and where it's going to be able to engage with employers effectively on that.
No, no question. I mean,
Yeah.
I
Okay.
hate to harp on this. Eternal vigilance. Eternal vigilance is about trying to think about everything all the time. What you've done, what you do now, how to improve what you do now, as well as hopefully rapid adoption of other potential solutions to help
Mhm.
manage the cost and quality of care. So concepts like that are really valuable. Conversations to vet those concepts are really important as well. And then deployment where they make sense with the right employer for the right population are something that we can support.
Okay, great. Well, thanks. I'm going to grab another one for you, Mike Sisk. So, what feedback do you get from employees and employers regarding satisfaction with virtual care? I mean, it's a pretty new thing over the last couple years for most
Yeah.
people. What kind of feedback are you getting about satisfaction with that kind of service?
Yeah, it's a great question. When I think about that, I really think about whether virtual care and the opportunity to receive virtual care is simply included in your plan or whether it's promoted in your plan. So when we think about all those things are available to, we'll just say consumers or members or employees or whatever they may be, there's a lot of really interesting stuff that's available to consumers. And I was thinking about things like nurse lines and EAPs and cost of care modeling tools and discount programs and um, virtual providers are in there as well as second opinion surgery guidance in some cases and quality comparisons. And you know what? None of them are very frequently utilized.
Hmm,
None of them. So when it comes to
interesting.
virtual care, I think it's just sort of often in there as included. And included doesn't get a whole lot of attention because mostly people
Yeah.
are trying to think about their health, their provider, and what it's going to cost them when and if they need to receive care, as well as the cost out of their paycheck. When it's promoted, it's an entirely different story. And I think the satisfaction goes up. Now, listen, I think it's relative to, you still have to have an interaction with the provider. And whether it's a traditional interaction or a virtual interaction, we can't predict how fulfilled someone is going to feel from that. I don't think I don't think mode of connection is necessarily the indicator whether it's good or not. But things we do here are the convenience is wonderful when it works. The ability to expand access has been great. I'll just give you one example of that. We have a client who said the need in the behavioral health space far outpaces the inventory that's available in the state of Maine right now. We have to address this within our population. This is really important. We just can't create more behavioral health professionals in the state. What can we do to expand access? And the answer was a virtual solution. It was called Talkspace. I mean, it's not necessarily important that it's Talkspace, but it is an example of how to do that. And that was a supplemental resource that allowed for those who were unable to receive or unable to receive in a way that was convenient for them to receive that sort of care that our client said is critically important to our ability to manage our workforce right now to respond to the issues that the workforce has and to keep them happy and productive through some really difficult times. These were caregivers, so I think the folks at Northern Light can appreciate this. And the life of caregivers over the last 2 to 3 years has been incredibly difficult. So that was just a really good expansion of promotion, a decision. It was an intentional strategic decision to access a source for care. It just happened to be virtual care, but it filled the need and it filled the need at a critical time.
Great. You can't help but wonder about the evolution. Like, I remember a time when people went to these places called grocery stores to get their groceries. Now it's either pick it up in the parking lot or have it delivered to your home. Same with books. I mean, Jeff Bezos knows a little about getting books in people's hands, right? Yeah, you wonder if that's going to change over time. So thanks for that. I'm going to make a couple of quick comments here. Uh, one of our participants, one of our audience members, is looking to connect with someone at Northern Light Health. We'll be able to make that arrangements outside of this meeting. And then a comment here, I love the portal and I use it 6 to 8 times a year. The best part is my conversations are documented. There's no room for misinterpretations of what I want to communicate to the provider. So Mike, I think it's your responsibility to send that check to that person for saying that. Okay, thanks so much for that. And then I do have a question for you, Mike Ross. Where does the elderly population fit into this new and ever-changing digital world? Sorry, I misread. Digital world, especially when they do not have a younger family member that can help them navigate through the digital systems. I've noticed they are falling through the cracks and becoming more and more frustrated, leading to avoidance of seeking out care. So that's a very significant observation. So if you could comment on some of that.
Certainly. One of the things that I mentioned earlier is allow patients the ability to make the decision of what they do and don't want to use. And we have seen actually a real surge in the use of the elderly in terms of utilizing technology. There are two main elements that are required for success with those who are not, we call digitally native, those who basically didn't grow up with technology, and so the adoption can be a little bit harder. The first one is it has to be user friendly. It has to be all in one place, and it can't be go to this and go to that. And that's what we really strive to do with the portal, to be that one central focus area. And that has been very successful. You'll note that our telehealth engagement, our online scheduling, everything is through that one central hub. The other area that's essential, I didn't mention this, but it's been a big part of us since the response to the pandemic, is there has to be an element of outreach that supports technology among patients. And so we started off with a telehealth help desk. Has transitioned that to a digital experience help desk, but there has to be a level of support that's offered to patients if they're having difficulty. Our medical assistants, our office PSRs, patient-facing staff, really we don't want them providing tech support. They've got plenty to do otherwise, but we want to make sure that is represented frequently and often in connections with patients. So that has been a real boon for involving those who may not have grown up with some of this technology and may not be as facile with it. And we've seen that I think the elderly, what we would consider those 70 and over, I think they're our fourth largest group. So they outpace actually some of our younger generations that are with the portal, largely as a result of those support networks.
And that's fascinating, isn't it? You know, I got a question for each of you separately. And think of it in terms of a 30-second response so we can wrap up on time. So Mike Ross, EICU, that's kind of a strange concept, and it goes into, hospital at home type a level of angst, if you will. Could you describe that a little bit more, and how are providers available to patients under those conditions? 30 seconds.
Absolutely. EICU is basically taking all that information that comes in from all those different sources and synthesizing it and being able to chart the medical care. Getting back to that history is everything topic, point I made earlier. When you're in the ICU, the information coming in is from all the monitoring elements, all that nursing report, and then there's a tiny bit of physical exam that provides that. But really, you can provide profound levels of care offsite. And so we have a relationship with a EICU group of doctors. They rotate at our outside hospitals and also at our major hub hospital, the Eastern Maine Medical Center. And they've done much to both stabilize those who are critically ill, as well as to arrange transport and support for those who require it during an emergency. It's been one of our more successful programs, and it really has opened up our eyes to the options available for virtual care.
Great. Well, thanks for that. And Mike Sis, this is real quick because we're at the end of the hour. So is virtual care blurring the lines of in-network and out-of-network reimbursement from plan design perspective?
Yeah, I think potentially it is, particularly if it's presented on a per unit cost basis. So here's your visit and it costs $59, for example. In that case, someone's not necessarily thinking about their plan of benefits and whether it's important to be in or out of network. So I think there is some issue there. And as it becomes a supplement to an otherwise standard network, yeah, I'm not sure that it
Yeah.
necessarily fits as an in or out of network option anymore as much as it is
Yeah. So we're
another
going to have
option.
to be pretty creative with that, particularly when we start thinking about e-consults at these big hubs like in Boston, et cetera. So, well, thanks for that. So we've reached the end of our scheduled time. We've included resources for you at the end of this presentation. Thank you all for joining us, and thank you to our panelists for great ways to enhance healthcare for people while decreasing the costs. I hope this hour will help you to successfully manage your business. Just a reminder, we will be emailing you a survey right after our conference. Please be sure to give us your feedback so we can continue to provide relevant information. Our next session will be on November 9th. Our topic will be Recognizing Lung Cancer Awareness Month. In recent years, we have enhanced our capabilities to diagnose lung cancer early. As you may be aware, time of diagnosis makes a big difference in the outcome of lung cancer, and we'll inform you about how to help others not waste any of that time. We'll also focus on prevention and discuss the many avenues to assist you and your employees. I hope you will join us. We will send you the link for this session. We encourage you to share the invitation with your friends and colleagues. By working together to promote good health, we will be promoting good business. Thank you and have a good afternoon.